Good morning. Good morning. This is Dr. Nick Tullo. And so I have a brand new setup and hold on a second. Oh my goodness. I had like two monitors that just went off, like just delayed, and it was like really crazy. But I think everything's set now. I'm now in my brand new studio, although I don't have everything done. There's another camera in the setup and everything. So, but it's a brand new version of Wirecast, which is the software that I use to stream this stuff. And so, in a brand new computer, a brand new iMac. So, it's not perfected, and if there are any technical glitches or anything that's not working right, please post a comment because I can see most of them. And anyway, I'm sorry it's been a few weeks since I did one of these because I was out of town at a conference 3 weeks ago, and then the week before last I was we were doing construction, so I couldn't get in here, and then last week I was on call. So yesterday was 12 days in a row that I had to work, and today was a great day. I got to sleep in this morning. Got up at 7 o'clock in the morning, but behind me is the painters are working on my basement room. So if you see any motion back there, the house isn't being robbed or anything. So don't worry about it. Anyway, if someone wants to post something, just so I know that things are getting out there, I would love to see a comment. Just anyone at all, say hi. Most of the time, you guys are pretty good at saying hi in the morning. Anyway, we're going to talk about a case that I saw this week, and it was a kind of crazy case because it was sort of an unusual story. And let me talk to you now about it. I'm just waiting for a comment. If anybody wants to share with me that they are watching, that'd be great. So the story is this. It was a 68-year-old fellow. Really had a history of an aortic aneurysm that was repaired with a stent graft about 3 years ago. But no history of coronary disease as far as we know, and had stress tests in the past that were normal. No hypertension, diabetes, and the guy was working. He actually works for a golf course, and it's the season, right? So he was cutting grass and trimming the greens and getting everything ready for all the golfers, and he had a whole bunch of silt that he had to shovel. So he was shoveling this silt and suddenly felt this lightheadedness. Felt very, very weak. Felt faint but didn't pass out. So he called for help and continued to feel lousy. So they called 911 and the paramedics came, and they said he was in a wide complex tachycardia. They called it V-Tach. And his blood pressure at that point was like 80. So they gave him some sedation real quick in the rig, and then they shocked him with 100 joules. But it didn't seem to work. He was still in V-Tach, so they did another 100. And then it still didn't work. At least the story that I got was they had to use 200 joules to finally get him out of this wide complex tachycardia. And then he wound up in a rapid, irregular, narrow complex tachycardia. So when he got to the emergency room, he looked like he was in atrial fibrillation with a rapid ventricular response. But within about 15 or 20 minutes or so, he converted back to a normal sinus rhythm. And of course, it was very exciting, but by the time he got to the floor, all the strips from the rig had disappeared. I don't know whether they hadn't saved them or they didn't record enough or whatever, but here I was now faced with this guy who looked fine. His cardiac enzymes turned out to be negative. He was hemodynamically stable with this history of wide complex tachycardia in someone who never had any history of heart disease in the past. So, I mean, where would you even start with that kind of a story? So at any rate, first thing, of course, is, ventricular tachycardia almost always occurs in the setting of some kind of underlying left ventricular dysfunction. Why? Because the vast majority of the time, ventricular tachycardia is due to reentry because of an area of slow conduction in the myocardium. So you have this reentry circuit that's going round and round, and it takes over the heartbeat and causes tachycardia to occur. So you can almost always find some evidence of myocardial infarction or cardiomyopathy or something. So we did an echocardiogram. That was the first thing we did. And what we saw was left ventricular hypertrophy. He had, moderate LVH. His wall thickness was about 1.4, 1.5, but his myocardium was squeezing just fine. His ejection fraction was normal. And even the right ventricle looked like it was contracting normally. So now what do you do? How do you figure out why this person had what sounded like V-Tach, but maybe it wasn't? I mean, could it have been some kind of atrial flutter with aberrant conduction that would give you regular narrow tachycardia? That would give you regular wide complex tachycardia because of the bundle branch block at rates of, who knows, 160 beats a minute or so, but wouldn't usually cause such severe hypotension, at least not under normal circumstances. And you can't really assume that it's an atrial arrhythmia and just kind of shrug off the whole V-Tach thing. And so what we did was we did a cardiac cath just to make sure that he didn't have significant coronary disease, that maybe he had an ischemic event. And the cath didn't show anything but ectasia. So the arteries were sort of like large and dilated and sort of like irregular in their caliber, but there wasn't any serious stenotic lesion. There wasn't a lot of atherosclerosis. So what would you do with this guy? Would you put him on medication? Would you recommend a monitor of some sort? Would you just assume it was atrial because he was, because we don't know? Well, I wouldn't assume it's atrial, but I mean, the rule is, if you have somebody with heart disease who has a wide complex tachycardia, 90% of the time it's going to be ventricular tachycardia. It's just the statistics. I always say that, it's kind of like if you're a resident and or an attending and they call you in the middle of the night and they say, Mr. Jones has a history of coronary disease as opposed to myocardial infarction. His ejection fraction is 30%. He is now in a wide complex tachycardia. He's hemodynamically stable. What do you think it is? You could just say, well, it's V-Tach. And you'll be right 90% of the time, even without looking at the cardiogram. So the problem is people are always they're afraid to call it V-Tach. They don't want to open this can of worms because, it's V-Tach. Now what do we do? So a lot of times people will look at a strip and say, yeah, maybe it's AFib with aberrancy or SVT or something like that. But we had no strip to look at. So what did we do? Well, I brought him to the electrophysiology laboratory because that's really ultimately the only way you're going to figure out what the guy had. Because if you stimulate his atrium and induce an atrial arrhythmia, and you can document whether he has rate-related bundle branch block or not. Okay, well, we did that. We brought him to the EP lab, and I'm going to share with you some of the strips that we saw. Okay, so let me see. Where's my Wirecast stuff here? Hold on. I'm going to switch over to my view here. Okay. Hey, it's White Adam from Alberta. Thanks for joining me, and Super Robrum from Roberto. Thanks, Roberto, for joining me, and thanks for the comment. Is everything sounding right? Is the voice synchronized? I mean, are the pictures okay? And like I said, this is my brand new studio, so I haven't had a chance to experiment with it and do some test streams and check it all. So this may be coming out lousy, but hopefully not. Anyway, here is the baseline EKG from the electrophysiology laboratory. Now, if you guys have gone through the advanced course on ECGacademy.com, I have a series of videos that show you how to read these things. So up at the top here, what we have is the surface ECG. You have leads 1 to AVL, V1, and V6. So, but it's a little spread out. Of course, you know, we run speeds much faster than a regular ECG, but you can see a P wave and a QRS complex and a T wave, and that's all, you know, looks fine. He's in a normal sinus rhythm here. This is the His bundle catheter. Okay, so what we see in a His catheter is 3 discrete signals. There's a very sharp A wave, which lines up with the atrial event, the P wave. And from the inside, we call them A waves. They're not P waves when you are dealing with an intracardiac electrogram. And then lining up with the QRS complex, you have a V wave, and then in between, there's a spike, a very sharp signal here, and that's the His spike, or H spike. That's actually the local activation of the His bundle. Because what we do is we put the catheter up the inferior vena cava. I'm not drawing really well here, but here's the inferior vena cava, and we bring the catheter up and we place it right at the septum here where the His bundle runs through, and we can measure the local activation of the His bundle. So let me show you the next recording, which is just a blown up version of the His bundle recording. So now we're running the paper speed like 4 times normal, 200 millimeters per second. And we have this large A wave, and we have this very large V wave, and in between there's this His spike. So we're able to measure AH interval, which is from here to here, and that tells us how long it takes for the signal to get from the atrium to the His spike, to the His bundle. So that really corresponds with AV node conduction, the AV conduction time, and we call that the AH interval. Then we can measure the HV interval, which is from the beginning of the His spike to the beginning of any surface or intracardiac ventricular signal. So the QRS starts over here at the R wave, and we can measure this HV interval, and it was actually normal. Just slightly abnormal, was about 60 milliseconds. Normal is 55. Sorry, normal was 35 to 55, and this was 60. And then you have the QRS, and T wave was all normal. Okay. Well, we put atrial premature beats in there, and even with close coupled atrial premature beats, I was not able to demonstrate any kind of bundle branch block, any kind of rate-related aberrancy. I could not get the QRS to get wide with premature atrial beats. So I moved the atrial catheter to the ventricle. And this is where things got very interesting. Okay, so this is known as programmed electrical stimulation, PES. What we do is we pace at a fixed rate, okay, and then we deliver a premature beat. And with single premature beats, he actually had like 3 or 4 run bursts of non-sustained VT. But here is 2 premature beats. Thanks for tuning in from Algeria. Wow, that's so cool. People from all over the world are watching. So here we're pacing in the ventricle. You can see it's ventricular pacing because it's wide and bizarre. And in fact, during the ventricular pacing run, if you look in the His deflection, in the His catheter, you can see what the atrium is doing. So where's the atrial signal? The atrial signal are these very large spikes right here. This one, that's an atrial signal. And here's another atrial signal. And look at that. You have atrial signals that are much slower than the pacing that we're doing. So during ventricular pacing, you have AV dissociation, which is common. When we see that with any kind of arrhythmia where the ventricle is faster than the atrium and you don't have one-to-one retrograde conduction up the AV node. So this is AV dissociation during ventricular pacing. So we have 1, 2, 3, 4, 5, and here's the 6th one, and then we put 1, 2 premature beats in as like a ventricular couplet. It's like we're giving the guy a ventricular couplet. That's all it is. And suddenly we have what is a little bit of a narrow QRS because I think this atrial beat got down. This was a capture beat. That's not what we're interested in. What we're interested in is this. Here is the wide complex tachycardia. Now, is this atrial with aberrant conduction? If you can tell right away, because if you just look at the HIS bundle, you can see what the atrium is doing. Here's the atrium. It's still marching through at a slow rate. So the atrial rate is much slower than the ventricular rate. And so this is sustained V-Tach. It was monomorphic. Every beat looks the same. In fact, here is the 12 lead of this ventricular tachycardia. And we're like, oh, wow, look at that. It's V-Tach. It really is V-Tach. The guy really had V-Tach. Well, of course, the medical resident who was with me was like, oh no, what do we do now? Okay, well, we have a wire in the ventricle. So all I did was I sort of measured the rate very quickly, and I set the catheter to pace just a little bit faster than the tachycardia rate. And this is known as anti-tachycardia pacing. So here you're in V-Tach, okay, and you can still see the dissociated P waves here. And so now what I do is I pace in the ventricle a little bit faster. I pace long enough so I can see that the pacing spikes are capturing the ventricle. And you know that because the QRS changes. Now it's the QRS complex is coming from the pacemaker lead, the pacing wire. And then when I stop pacing here, the ventricular tachycardia has been terminated and the patient is back in a normal rhythm. And so now it turns out that he had several different VT morphologies. This one, if you look at the 12 lead, it looks from here, V1 through V6, it looks like a classic left bundle branch block with a deep negative QRS complex with a little tiny R wave, and the R tends to grow, and then you have kind of larger R waves here in the V4, V5, V6, and the axis is kind of headed towards the feet. It's isoelectric in 1, and it's positive in 2, 3, and AVF. So it's kind of coming from the base, and so traveling towards the feet, but it's originating from either the septum or the right ventricle. So gee, he really had V-Tach, and with a normal ventricle, and with fairly normal coronaries. It was astounding. I was really kind of surprised to see this, but now that I knew that this guy was at very high risk of a recurrent tachycardia. So, but there was just one question that I had: why would someone with a normal ventricle have V-Tach like this? So how would you assess the ventricle with a little bit more? So we actually did, after this, we thought maybe he was having some ischemia, and we did a Lexi-scan nuclear stress test, but that was negative as well. So we sent the patient for a cardiac MRI. It actually took a couple of days to arrange that. We had to send him to a different hospital to get the cardiac MRI. And what it showed was normal left ventricular function, normal right ventricular function, but there were areas of what they call delayed enhancement. Areas that lit up in the septum, on the inferior wall, a little bit in the RV, that were signs of abnormal heart muscle tissue. So it could have been inflammation. He could have early signs of infiltrative cardiomyopathy, but it wasn't diffuse, it was focal. And so it could have been some ischemia or some scar tissue or something like that. But clearly the heart muscle was not normal. And so we elected to recommend an implantable defibrillator. And so that was implanted 2 days ago, and he did great. I just put a single chamber ICD in the ventricle. Now the interesting thing is, I put the wire in the ventricle, it tickled, had a couple of PVCs, and he went into V-Tach during the implant. So I jiggled the wire a little bit, had a couple more PVCs, and it broke. And then I jiggled the wire a little bit to get it into a good spot, and he went back into a different V-Tach. I was like, oh my God, there's so many electrical short circuits that, for some people who have monomorphic VT like this, that perhaps is hemodynamically stable and that is recurring, you could potentially map this and offer the patient a catheter ablation of some sort. The thing is, he clearly had multiple morphologies coming from different spots in the heart. And if you ablated one or maybe two of them, that wasn't going to guarantee that he was going to be cured or arrhythmia free. So I elected to recommend the defibrillator. We put the defibrillator lead in a good stable spot, tested it, everything worked fine, and then he went home like 2 days later. Now, afterwards, he had some runs of non-sustained VT, so I thought maybe the wire might have been a little, sort of like irritable until things settled down. I put him on a little bit of amiodarone, but I figured after a month or so, once everything has been stabilized, I would take him off of it and just leave him on a beta blocker. Because he's a young guy, you don't want to leave him on amiodarone long term, but you want to see whether, how often he gets treated for sustained VT. Now, the cool thing about the defibrillators is that they are capable of delivering the same anti-tachycardia pacing that I delivered in the lab. So you program it for a certain rate, say 167 or 175 or whatever beats per minute. And above that rate, the defibrillator would automatically measure the rate of the tachycardia and then pace the patient's heart a little bit faster, a certain percentage of the cycle length, to break it up. It's known as anti-tachycardia pacing. And it will do that multiple times. And it will attempt and change and alter the pacing rate and how long it paces until the program is exhausted, and then it will go ahead and deliver a shock. Now, you can program a second rate, a ventricular fibrillation rate, where it'll try pacing maybe one time while it's charging up to deliver that shock, because you figure if it's a very rapid ventricular arrhythmia, patients may be hemodynamically stable, unstable, and you don't want them to kind of like deteriorate or pass out or become ischemic while you're testing or while the device is delivering anti-tachy pacing, and then it has to wait and look to see if it worked, and it has to count up to re-diagnose, and then it has to deliver another. So it could take like a minute before the first shock for ventricular tachycardia. But for ventricular fibrillation, it'll charge up immediately, and it'll attempt one burst of pacing before it delivers a shock, maybe in 10 or 15 seconds into the arrhythmia. Okay, so that's how they work. And for this patient, it seemed to be the ideal solution because he, if he goes into V-Tach, the pacemaker would get him out of it, and he may not even know, he may not feel it. A lot of patients don't even realize they come back and oh, look at that. You had a tachycardia event 2 weeks ago and the device handled it and everything's fine. Now, here's the thing. If he has multiple episodes of V-Tach, then maybe you might consider referring him for an ablation to reduce his burden of arrhythmia, and that would potentially reduce his chances of getting a shock. So I'm looking at some of the comments here. Brian Gomez, good morning. I'm glad you were able to join us. And Dr. Owens, thanks for joining me from the UK. I mean, that's like so cool. I really appreciate it. I did it a little bit later than usual, but I guess, over in the UK or sort of late in the evening, and it works out okay. And of course, my California viewers probably haven't had their first soy latte yet, so it's only 8 in the morning over there. And so Wyatt has a question. Wouldn't it hurt the patient if the patient's in VT with a pulse to get cardioverted? Could it be dangerous if he's driving? That is an excellent question. So let's talk about shocks that these defibrillators deliver. When you use paddles, how many joules do you deliver? 100, 200, so it's a big shock and the whole body jerks. But of course, you're delivering the energy through the muscles, and so that's a lot of why it jerks. Defibrillators deliver up to a maximum of about 35 to 40 joules. But for a stable tachycardia like this, sometimes you can get people out of it with as little of a shock as maybe 5 joules, or even lower. But the thing is this, the studies have shown that even with an internal defibrillator, you still get stimulation of the muscles because the box is part of the circuit. So the shock is actually delivered through a spring coil in the right ventricle, and the shock has to go through from the can to the coil, and you get stimulation of the muscle. So anything over maybe 0.5 joules is perceived as painful. So yes, a 5 joule shock hurts, but 35 joule shock hurts like heck. People have described it as getting kicked in the chest by a mule. So that's why we rely on anti-tachycardia pacing to try to terminate tachycardia because that has no perceived discomfort. And it's now been shown that if you prolong the number of intervals to detect, a lot of times V-Tach will stop by itself, so the patients won't get a shock. And the anti-tachycardia pacing is very, very effective, probably 90% of the time, to terminate tachycardia and avoid the need for a shock. So in the event that someone has a very rapid tachycardia and they're hemodynamically unstable, you don't want to delay that shock necessarily, because then they may become ischemic. And then it may take more energy to actually terminate the arrhythmia. It may accelerate. It may turn into ventricular fibrillation. And the devices, we test actually. We burst pace and induce ventricular fibrillation in the lab while we're implanting it. And we let the device shock the patient out of VF, fine VF, to make sure that it works even under the worst possible circumstances. And it did in this case. That's why we do it under deep sedation, so they don't feel anything, they don't remember anything. But you're right, you have to be careful. But it turns out the studies have been done with patients with V-Tach who are driving, who have defibrillators, and getting a shock while you're driving is not nearly as common as getting a shock after you're driving. So it actually doesn't occur very often. But yes, it could be very, dangerous to have a shock go off while you're operating a motor vehicle. So we try not, in people who have frequent unstable tachycardia, we tell them not to drive. That's the bottom line. But having a defibrillator doesn't always prevent you from driving it, but you do have to take all these things into consideration, and everybody has to be treated, individually, make individual decisions. Jamshida here, thank you very much. I'm really glad that that you're enjoying these. And by the way, if you enjoy this content, please make sure you tell all your friends to subscribe to my YouTube channel, ECG Doc, and that's why they'll be able to watch these on YouTube, and you'll also be able to see them if you're a subscriber for ECG Academy, where I have a lot more content and all the Chalk Talks. We're looking forward to ECG Chalk Talks too. You know why? I'm about a month behind. I do them every week, but I'm about a month behind because of all the construction, because I'm redoing my equipment and software and everything. But I plan to catch up in the next 3 weeks or so. I have a lot of time coming up, so I'll be able to catch up with it. Oh, Roberto, thank you very much. I'm glad you enjoyed this. And Wyatt, thanks for asking the question. It's really terrific to be able to interact with you guys. And I really appreciate your joining me on this Saturday morning. I hope to keep doing these week after week and get the word out. So, get you guys to understand how arrhythmia specialists think and how we treat these complex patients. So if you have any other questions, that's great. Otherwise, I will hopefully see you next week. And, maybe by then my setup will be a little bit more refined and we won't have the painters in the room behind me. So anyway, I hope you have a terrific week, all of you. And anyone, if you have a question or something, you can always drop me an email at drnick@ecgacademy.com. And don't forget, ecgacademy.com is a great place to learn basic and advanced arrhythmias, and check it out if you want more advanced stuff. Until next week, this is Dr. Nick Tullo. I'll have a great time and see you then.